Overstretching can be harmful for any dancer, whether you're hypermobile or not. So we want to be super, super careful about that. Oversplits, maybe a little bit, but like overstretching kind of by definition is overdoing it, right? So we want to be really, really careful because hypermobile dancers already have enough range. We want to focus on strength, proprioception, active flexibility. So I'm definitely not anti-stretching. I'm pro-purposeful stretching. And what I recommend that all dancers do, actually, whether you're hypermobile or not, if you possibly can, work one-on-one with a dance medicine physical therapist or a dance medicine Pilates instructor. There are a lot of people who are just really outstanding working with dancers, and those people can really help you figure out, like, why does this thing feel tight and what should I do about it, rather than, kind of more generic things that we might look up online. And you want to make sure that you are doing what your body needs.
Dr. Linda Bluestein, welcome to the Ballet Science Podcast. It is truly a pleasure to have you here today, and I'm so excited to speak with you.
Well, thank you so much for having me. I am really excited about this conversation.
Great. So to start off, do you mind introducing yourself and telling everyone just a little bit about your background, your work as a physician, and then how you became interested in hypermobility and EDS?
Like many, many young ladies, I grew up wanting nothing more than to be a professional ballet dancer. And I was very, very serious about it until I started to get lots of injuries and mysterious problems. And it was like, wait, maybe we need a plan B here. So I ended up deciding, well, if I can't be a professional ballet dancer, maybe I'll be a doctor. So went to medical school, went through all of the regular thing, became an anesthesiologist. And then I worked as an anesthesiologist for more than 2 decades when my health problems caught up to me again. Not that I didn't have lots of health problems in between there. I did. I had lots of health problems, but I couldn't work in the operating room anymore. So I realized that the same thing that caused me to have all these problems was something that was common in dancers. And I thought, oh, this is a great way to combine my love of science and my love of dance and help dancers understand their bodies and be proactive with their health.
Wow, awesome. That's such an interesting story. So can you tell us what exactly is hypermobility? I know that term gets thrown around a lot these days. And when we're talking about flexibility, hypermobility, EDS, could you help us come up with some definitions for all of those things?
Yeah, it's really interesting to have this conversation now because, I'm 200 episodes plus into my own podcast, right? So when we first started having these conversations, I feel like nobody in the dance world knew what hypermobility was, or very few people, I should say. And I feel like now everybody knows what they've heard the term, right? But it can be misunderstood for sure. And EDS and things like that can be misunderstood. So yes, I love this question. So joint hypermobility means that a joint or a group of joints has greater than expected range of motion. So think of the hyperextended knee, the hyperextended elbow, being able to do party tricks, being able to do the splits even is like that's more than what normal, quote unquote, normal people or the average person can do. So that's what hypermobility is, joint hypermobility. That's what that refers to. And then Ehlers-Danlos syndromes are a group of connective tissue disorders. They're the most common type of connective tissue disorders. And the hypermobile type of EDS, or hypermobile Ehlers-Danlos syndrome, is by far the most common within that umbrella. So we know that a lot of people that are hypermobile do end up eventually getting symptoms related to their joint hypermobility, and some of them do have hypermobile EDS. People who don't meet the criteria for hypermobile EDS or some other condition to explain their symptoms related to their hypermobility, they're diagnosed with hypermobility spectrum disorders. So we know that hypermobility can be a completely innocent finding. Some people never get any problems related to it at all, but other people develop problems over time. And a lot of those people now, we believe, have hypermobile EDS or HSD.
Thank you. Yes, I think there's a lot of overlap, but then also they're each their own thing too. So it's good to have those definitions. So obviously lots of dancers are praised for being so naturally flexible. At what point would you say that flexibility sort of crosses the line from being an advantage to something that could be potentially a serious health concern, like maybe you experienced during your time as a dancer?
I would say it's a couple of key things. Number one is control. So, are you able to control your flexibility? That is a huge point right there because your flexibility absolutely is an asset in dance, but not if it exceeds your control. You want to make sure that you have stability in addition to mobility in order to optimize your injury risk. Most all dancers are going to get injured at some point in time. So I usually don't talk about injury prevention. I talk about injury risk reduction because that's more appropriate. And the flexible dancer, you know, it's funny because I've had dancers say, well, I'm not that flexible. And it's like, but you're comparing yourself to other dancers, right? Not quote unquote normal people. So within the dance community, there's such a high prevalence, and I know we're going to talk about this later, like why it's so common, but it's important to think about, how am I relative to quote unquote normal people, but also know that the most flexible dancer is not necessarily the one that is going to have the most problems. It's not necessarily the one that's going to have hypermobile EDS. You can have people who are very hypermobile, and maybe it's for a different reason. Maybe they don't have an underlying connective tissue disorder. Maybe they have, it's the shape of their bones or some other reason why they're able to achieve, those aesthetic lines and things like that. But somebody else might have a connective tissue disorder and maybe their muscles are holding on for dear life. And we're going to talk about that too. And maybe that's why they don't look like they're as hypermobile, but they have more problems later on. So I'd say it really comes down to like, can you control your flexibility? Not just like, how flexible am I? Are you sinking into positions and things like that? And, flexibility is so important in dance, but we wanna make sure that we're optimizing our flexibility and not just relying on it. A lot of people, my podcast is called Bendy Bodies, right? There's a lot of dancers that I've worked with that are quote unquote retired at age 12 or 13, and they used to be getting the Bendy award or, the one that was doing the needle or whatever in the front of the class. So, more is not necessarily better.
Absolutely. So, why do you think hypermobility seems to be so common in dancers and even other performing, arenas? Do you think the art form of maybe ballet or just dance in general attracts people who are hypermobile because it does reward some of the extreme positions? What do you think is going on there?
All of the above. Yeah, it definitely, if you're not very flexible, you're probably not gonna stay in dance, especially ballet. You're not gonna stay in it very long, right? Because you're just not able to achieve the lines and things like that. So I think definitely naturally flexible people are drawn to dance in the first place. And if you're more flexible, have more joint hypermobility, you might stay in dance longer, so long as you're able to stay healthy. And also, we know that dance training increases flexibility over time. We're training to be more flexible. In fact, it's funny because one of the points for the Beighton score, which is something that we do to assess for generalized joint hypermobility, is can you put your palms flat on the floor without bending your knees with your feet together? Well, think about if you're doing cambre forward, right? Like that is you're pancaking your body, And I remember as a dancer, like I didn't think anything of it. Everybody in the class could do that, right? So it's also a little unclear if we should be using different criteria for dancers because they're training for hypermobility in a sense. They're training to maximize their mobility. And we know that it's actually really common in musicians as well. But classical ballet dancers have very, very high rates of joint hypermobility. They benefit tremendously aesthetically and technically from being super flexible. But we need to know that not all dancers, not all hypermobile dancers have hypermobile EDS. And we also want to be thinking about, the period where we're growing a lot and really balancing our flexibility with strength and control during those times.
Great. So, What are some of the signs that a dancer's hypermobility might be starting to cause them some problems? So, since again, it's so common in dancers, and maybe again, it seems normal in a ballet class, like you said,
Right.
everyone can touch the floor, everyone can lift their leg up high, or do a
Right.
needle or whatever.
Heel in the hand, yeah.
Exactly, yeah. So that it seems normal in ballet when that's what you're comparing yourself to. But what are
Right.
some of the signs that it might be something that deserves, speaking to a specialist like yourself, or just kind of maybe seeking out a diagnosis?
Mhm, mhm. So, ankle sprains are quite common, right, in the general population, like, I mean, I don't know if I know anybody who hasn't, like, at least once sprained an ankle, but if you're spraining an ankle frequently and you're getting other recurrent sprains, if you feel like your joints kind of slip in and out of position or if your joints feel unreliable, um, you know, it's so interesting because I've talked to some physical therapists and they're like, when you're doing the splits or, probably other extreme positions in dance, you really are subluxing your hips. Your hip is no longer in like quote unquote, the proper position or fully correct alignment. And so even the fact that you can do that is a very interesting thing. So it's really important to pay attention to those dancers that tend to get more nagging injuries. They don't heal as quickly. They might have fatigue, headaches. They get more dizzy when they stand up, which we can probably talk about that more later. Like if you get dizzy when you stand up, that could be just that you're quote unquote dehydrated. I don't know why I put that in quotes. It could be just that that you're behind on your fluids, and everything, or it could be a sign that you have POTS or postural orthostatic tachycardia syndrome, which often comes along with hypermobile EDS. Headaches are very, very common with hypermobile EDS and HSD, and all types of headaches. So cluster headaches, migraine headaches, tension headaches, sinus headaches, like all of those are more common in this population that has these conditions, the hypermobile EDS and HSD. Things like jaw pain, clicking, longer recovery. Somebody who has these conditions might feel like they're working harder than everyone else just to keep up or just stay in a more stable place. And so those are some of the things. And then also people who have kind of chronic muscle tightness, they also might be having muscles that are kind of trying to hang on because their ligaments are more lax and their ligaments are not holding the bones where they normally would.
Very interesting. Yes, and so many of those boxes, I think I was like, "Oh, I can check a lot of those."
Yep.
So,
Yep.
makes sense.
Yep.
But it's so many other things besides just, being able to do a split. And again, we're gonna get into that a little bit later. So thank you for all of that. So what is the diagnostic procedure like for, EDS or specifically HEDS? And what are some of the challenges or maybe the most common challenges people run into when trying to get a diagnosis or just kind of get some answers?
Mhm. Yeah, I'd say one of the biggest problems is the stigma. We kinda went from nobody knowing what it was to now, unfortunately, and I hope that I have not made this worse, but, there are doctors that call this, like, the TikTok disease, and it's like, "Oh my god," that's awful. It's absolutely horrible. People are suffering, and I've seen in doctor forums, I've seen people say fibromyalgia is the F word and EDS is the E word. It's like, "Oh my gosh." People are suffering. I mean, the things that they're suffering with, they can get really, really bad. A lot of times, once dancers stop dancing, I've seen quite a few cases where, kind of one thing happens, then that leads to another thing. And it's like, wow, how did I hold it all together that well for that long and manage to actually, dance professionally or dance very seriously? And then all of these things started to happen. So the first thing I would say is the stigma. The second thing is that these are clinical diagnoses. So we don't have a biomarker, we don't have a genetic test, we don't have a lab test to confirm hypermobile EDS or HSD. So it is based on somebody with the proper training, knowledge, and time, because it's time consuming to go through these criteria. And you need to really have seen a number of people in order to determine, like, one of the criteria. This is the 2017 diagnostic criteria, and we're gonna be getting new criteria later this year. Um, so this is gonna be changing, but one of the criteria is soft, velvety skin. As compared to what? Like, that's a hard one, right? You have to feel a lot of people's skin in order to know. Like, I have some people that really have doughy skin, like really, really doughy skin, and other people, it's like, what I call this soft and velvety, it's a little less clear. So it's really difficult sometimes to sort all that out. And the three core features of EDS or HSD are that you have joint hypermobility and or joint instability. That's where the joint has difficulty staying in proper alignment. You have weak tissues, so you might have pelvic organ prolapse, hernias, a variety of places where you demonstrate weak tissues, and then also changes in the skin. So scars that are wider side to side and thinner, like deep wise than normal. And you also might have stretchy skin. So if you have extremely stretchy skin, then we need to think about other things like classical EDS. But people with hypermobile EDS have mild skin hyperextensibility. So those are the three core features that are important to be aware of from a diagnostic standpoint. But it's tricky because there's a lot of overlap with other conditions like acquired connective tissue disorders, like rheumatoid arthritis, lupus, Sjogren's. So it could be very tricky to sort those out. Fortunately, those have biomarkers. However, we also have like seronegative rheumatoid arthritis, and we have things like Sjogren antibodies that we can test for, but they're not always positive. So those kind of things are really tricky. Another challenge is that a lot of people are gaslit and they're told, oh, you're just flexible, you're just anxious. Anxiety is super common with joint hypermobility, but that's not usually the explanation for your symptoms. It could contribute, but then when you go to the doctor and the doctor says, oh, you're fine, your lab test came back normal, so you're fine, not saying I believe you, which is what they should say, right? Instead, they say, oh, you're fine. That gaslighting makes you more anxious and makes your symptoms exacerbated and makes you feel worse usually. And the symptoms usually involve multiple body systems. So that also makes diagnosis challenging because we're taught in medical school, like, if a person has this and this and this, then they have that. And here you have somebody who has symptoms often in a bunch of different bodily systems.
Yeah, the complexity is something I think a lot of people don't truly understand. So thank you so much for explaining all of that and just how it affects so many other systems besides, just the joints or the ligaments or whatever. So that was a great explanation. So you mentioned ankle sprains. Are there any other, and maybe hernias, things like that, are there any other injuries or complaints, like physical complaints, that are probably the most common in hypermobile dancers specifically?
I would say one of the most common ones that I see is subluxation or dislocation of the patella, which is the kneecap. And unfortunately, once you fully dislocate a joint, it's easier for it to dislocate. So I've worked with quite a few dancers that have recurrent patellar dislocation to the point where they eventually have to have surgery for it. And of course, that's a very problematic thing. Shoulder instability is also very common. Back pain, neck pain, jaw pain, as I kind of mentioned earlier. We see a lot of recurrent hamstring and other, muscle strains. Snapping hip syndrome is very common, and that's not always a hip kind of going out of alignment, but it could be related to either the IT band, which is on the outside of the leg, or the iliopsoas muscle, which is deep inside and in front of the hip socket. So those things can also be problematic. I know I already mentioned about ankle instability. We can see a lot of problems in the hips. So dancers put a lot of range of motion right through their hips. They are doing a lot with their hips. So we see a lot more things like labral tears, which may or may not be symptomatic. Sometimes they have asymptomatic labral tears. That's the lining inside the acetabulum that we have in both the shoulders and in the hips. We have a labrum, and you can get a tear of that. There's also something called the ligamentum teres, which connects the femur to the acetabulum. And people used to think that that was not important, but that can get torn. And so I get pretty cringy when I see people doing oversplits and, I understand, okay, maybe a little bit of oversplits, but I see people doing really extreme stretching. And if you tear that ligamentum teres, that is a very important stabilizer for your hip joints. And it also helps with proprioception and helps distribute lubricating synovial fluid. So this thing that people used to think is not important actually is important. And there have been some dancers that have had hips replaced at a younger age. So it's just so important to think about, how do I optimize this person's flexibility, but while making sure that we do everything we can to optimize their longevity in dance. Because a dancer who peaks at 12 or 13 is not really, in my opinion, probably achieving their dream of being a dancer for a longer period of time. So, we really want to be paying attention to dancers that have, groin or hip pain, if they have clicking, locking, instability sensations, things like that, things that are also common, like I mentioned earlier, fatigue, slow recovery, and chronic pain.
So, speaking of stretching and overstretching, obviously, stretching and flexibility in general is a huge part of dance and ballet specifically.
Hmm.
So, if a dancer is hypermobile, should they be stretching differently than maybe their other classmates who are not, or the same, different? What advice would you give in terms of stretching for these dancers?
Hmm. Stretching is very important. I mean, it's funny because I avoided stretching completely for a period of years because I thought that that was making my problems worse, and I wish I hadn't done that because I now have parts of my body that I think are much tighter than they would have been if I had continued to stretch in the proper way, not just going crazy and hanging out in passive stretches. That's one thing that we want to be very careful about. We want to do more active stretching, so, not just hanging out in a position for, prolonged periods of time, like minutes, right? Um, Tight muscles are not always short muscles. Sometimes a tight muscle is doing protective muscle guarding, and something like rolling out those muscles can be really helpful. And I interviewed somebody named Jill Miller for my podcast, and she has some great rolling tools, and I would encourage people to check that out. We can maybe link that in the show notes. And also fascia. Fascia is what coats, it's the thin layer of tissue that covers our muscles. And so it's really important to be thinking about how is our fascia. And I talked to Dr. Tina Wang about that too. Overstretching can be harmful for any dancer, whether you're hypermobile or not. So we want to be super, super careful about that. Oversplits, maybe a little bit, but overstretching kind of by definition is overdoing it, right? So we want to be really, really careful because hypermobile dancers already have enough range. We want to focus on strength, proprioception, active flexibility. So I'm definitely not anti-stretching. I'm pro-purposeful stretching. And what I recommend that all dancers do, actually, whether you're hypermobile or not, if you possibly can, work one-on-one with a dance medicine physical therapist or a dance medicine Pilates instructor, and they can go to iadms.org, iadms.org, to find a dance medicine specialist. There are a lot of people who are just really outstanding working with dancers. Jennifer Milner, my OG Bendy Body's co-host, is one of them in Dallas, Texas, but she works with people virtually. And those people can really help you figure out why does this thing feel tight and what should I do about it, rather than, kind of more generic things that we might look up online. And you want to make sure that you are doing what your body needs.
Excellent. Yes, that's all such excellent advice. And yes, any resources that you have, I will happily link. Again, you have that fabulous Bendy Bodies podcast, and you've had so many wonderful guests. And yes, I'm constantly plugging iAdams on here too. So thank you
Yeah.
for mentioning that. Another
Yes, of
wonderful
course.
resource. Yeah.
Yep. Yep.
So, speaking of strength training, so in terms of strength training, what should hypermobile dancers be doing or keeping in mind when it comes to incorporating some strength work to sort of balance out their mobility?
Hmm. So we all can benefit from having more muscle tone, and that helps stabilize our joints. So if we have more muscle that helps stabilize our joints, that helps us with fatigue, actually, because we need that muscle mass in order to get energy. And our muscles also will help us with proprioception, balance, and endurance. And the goal is more resilience, not necessarily, as dancers, right, we don't want to become bulky. But for most females, I feel like that usually is not a problem. I feel like most people don't need to worry about getting overly bulky. And if they start getting oh, I'm starting to develop a little more muscle in this particular area that I want, you can always back off, right? So strength training, resistance training is so, so important. And again, if you possibly can, work with somebody one-on-one so they can look at your form. They can be telling you, yes, you're doing this correctly, as compared to, doing it on your own, which of course a lot of people have to do that because they can't afford the one-on-one support. But if you can, definitely think about that. And then also prioritizing control over load. You're better off lifting less weight with more control than lifting more weight and doing it in a sloppy fashion or using momentum. It's funny. Probably have more female listeners than male listeners, so hopefully they won't be offended if I say this. But when I go to the gym, I notice the women, for the most part, are doing things like slow and controlled. And a lot of the guys are like herky-jerky, like fast, and using more weight, right? So if you can use lower weight, go slow. The eccentric phase, when you're lowering that weight, so think of like a bicep curl. When you're lowering that weight, that's extremely good for your tendons. Tendons, we know, get stronger with eccentrics. So don't just do the bicep curl and then forget about that eccentric phase. The concentric phase is when you're shortening the muscle, and the eccentric phase is when you're lengthening it again. But both phases are important, and especially for hypermobile dancers, that eccentric phase is really, really important. So start low, go slow, be consistent, have control, and just, try to build up some muscle to help support your joints.
Perfect. Thank you so much for all of that incredible advice. And yes, eccentric contractions are overlooked a lot of times. So thank you for
Yes.
mentioning that too.
Yeah.
I agree completely with that. So we've covered, stretching, strength training. Earlier, you did mention some of the sort of other symptoms that can come along with hypermobility or EDS. Could you speak a little bit more about some of those things like fatigue, like you mentioned, dizziness? I think I've even heard digestive issues sometimes
Oh, yeah.
too.
Oh, yeah.
Could you talk a little bit more about some of that and maybe some things that people could be on the lookout for
Mhm.
themselves?
Mhm. And I love this question because the sooner people start paying attention and getting this information, the better off they are. So we don't want to over medicalize anybody. I'm not going to take somebody who's like relatively healthy and start putting them on medications. But if they are hypermobile and they start getting the information about what to do with their hypermobile body at the earliest possible time, that's going to help them in terms of their career. So connective tissue is everywhere in the body. So it makes sense that people could have symptoms anywhere in the body. So for example, connective tissue is in your digestive tract. So it can cause more dilation of your colon, for example, and that can cause constipation. You can get more dilation and slow digestion through your stomach, which is called gastroparesis or delayed gastric emptying. And you can get more bacteria overgrowth in your small intestine. That's called SIBO, small intestinal bacterial overgrowth. A lot of people have food intolerances, abdominal pain, fatigue. There's something called postural orthostatic tachycardia syndrome that I mentioned earlier that happens more commonly in people with EDS and HSD. And if people have POTS or postural orthostatic tachycardia syndrome, postural orthostatic, you go upright and your heart races. But really, it's not a cardiac problem. It's not a heart rate problem. It is a nervous system problem. So you get dizzy when you stand up. You get the black shades coming in. I remember, this used to happen to me all the time when I was younger, and I didn't know that wasn't normal. And I have patients say that to me all the time. They're like, "Oh, that's not normal. Like everybody doesn't have that." Any of us, if we're dehydrated, like I said earlier, or maybe we've had the flu, so we've been in bed for a few days, like then we can get that kind of symptoms. But if you have these symptoms for more than 3 months, dizziness, rapid heart rate, intolerance to upright posture, you can't stand in line very well or you might be leaning on the bar in the back of the room rather than just standing because you get dizzy when you're standing still in the back of the room because your blood is pooling in your legs and you're not getting enough blood flow to your brain. But if you start moving again, that helps. So you're kind of a antsy person who tends to move around a lot. Also, brain fog is another common thing, and exercise intolerance, which, believe it or not, definitely can happen in dancers. So if you're somebody who you're like, wow, why do I have so much more difficulty than other dancers when we're doing, snow, for example, that's a possible explanation. Also, mast cell activation syndrome occurs much more commonly in people who have EDS and or POTS. In fact, there was a recent study, I know you understand odds ratios, but there was a study looking at people who have hypermobile EDS and POTS, and the odds ratio for having mast cell activation syndrome was about 35. So 35-fold increased risk of having mast cell activation syndrome if you had hypermobile EDS and POTS. And mast cells are part of your immune system. So if you have mast cell activation syndrome, your mast cells are kind of going crazy, they're overreacting, and they cause things like hives, itching, rashes, gastrointestinal problems. It can cause that same kind of brain fog, digestive problems, as I mentioned. So that's skin, lungs. So the mast cells are everywhere that we interface with the environment. So you can get pulmonary problems like asthma and, more shortness of breath, chest pain. You can get genitourinary problems because it also lines the genitourinary tract. So there's something called bladder pain syndrome that is quite common if people have mast cell activation syndrome. And with the digestive symptoms, it could be reflux. People could get also diarrhea and or constipation or alternating diarrhea and constipation. We see a lot of sleep issues. And most people don't realize that these things are all connected, including doctors, unfortunately.
Yeah, I mean, that's such a long list of
Yeah.
things you mentioned there that, like you said, could be so many other things too. So I can see how this can be missed, or not just kind of all put together into one cohesive, like, oh, this is all connected.
Yeah, and I want to say something about that, if I may. When I first started learning about mast cell activation syndrome, I remember thinking, they're just throwing everything in there. Like, this is just a kitchen sink, kind of diagnosis. But the challenge is mast cells have over 1,000 mediators. They have over 1,000 chemicals. So when they release their chemicals, depending on which chemicals they release, they can cause so many different symptoms. So the challenge is in medicine, what are we doing? We're always looking at patterns. So it's really looking at the pattern of these things. And while there's some things that are more specific, like anaphylaxis, people whose throats close up when they're exposed to things, it's not always mast cell activation syndrome, but it can be. So we want to just be looking at patterns and evaluating each person individually.
Definitely. So I guess, we kind of talked about, okay, so maybe if you're a dancer and you've experienced any of these things, maybe you should get checked out. What should parents or dance teachers even, are there things that they can be on the lookout for with their students to maybe help get them a diagnosis if needed?
hmm Well, I hope I can put in a plug for my podcast here.
Please do.
Yeah, yeah. So I would first recommend that they listen to the Bendy Bodies podcast because it's free, right? And they can get a lot of information through that and also through my Substack newsletter. And that will help them determine kind of the next steps. So are you going to seek the assistance of a dance medicine physical therapist or Pilates instructor because you need more help with that kind of thing? Or do you need to see a physician to possibly get a diagnosis? The challenging thing is that there are very few of us who specialize in these conditions, and I don't want to say average PCP, but I'm just going to say that for lack of they have 6 minutes to see you, right? So they may or may not have heard of EDS, but even if they have, especially if you're actively dancing, they're probably going to go, oh, well, you couldn't have that. So I think that for most dancers and dance parents, a very, very good first place to start is with the iAdams website and finding a dance medicine physical therapist or Pilates instructor, gyrotonics instructor, something like that, and listening to the podcast and checking out the newsletter.
Great. Yes, I would agree with all of that for sure. So yeah, I definitely will link Bendy Bodies podcast again. Incredible 200 episodes, or you just passed 200 episodes. So congratulations on that. But yes, wonderful resource, and iAdams too. Yeah. Great. Let's see. So some dancers who are afraid, or they might be afraid that a diagnosis of EDS, hEDS, or any of these things might mean they have to stop dancing. And you kind of mentioned that a little bit with your own story. What would you say to those dancers who are maybe still trying to balance, their love of dance with managing some of these symptoms that you've mentioned? And what would you recommend for them?
hmm So to me, a diagnosis is information. It's not, oh, now I need to stop dancing. I know that I I believe that I have interviewed people on the podcast before that have said, like, I don't think dancers with EDS should dance. And I disagree with that. I personally think that if you're doing it in the best way for your body, dance is something that can be incredibly beneficial. And I should have mentioned this earlier, but another thing that I think is so, so important is for each dancer to identify their individual goals. Are you wanting to be a professional dancer? Then your path is going to look very different and your choices, of course, will be different. Or do you want to just dance for fun, then you're going to make different choices. Like, to me, why go on Pointe if you're just doing it for fun? Like, I had a dancer in their 30s who was already having foot pain, and I diagnosed her with hypermobile EDS, and she said, well, my whole adult ballet class is going to go on Pointe. And I said, well, do you want to go on Pointe? She's like, well, of course I'm going to go on Pointe. I said, but do you actually really want to? And she was like, we talked about it, and she decided not to. So I think it's just really important to always have your goals front of mind so that you can make the best possible choices. To me, dance is such a wonderful, beautiful thing, and I want all dancers, whether they have hypermobile EDS, HSD, none of the above, some other condition. I've met dancers that have, Louis-Dietz syndrome, which is another connective tissue disorder, and other, classical EDS and other forms of EDS. I want all of them to be able to dance and move as long as they possibly can.
Absolutely. And that's something that on my own podcast here, I focus on a lot, like, longevity. And I have lots of listeners who are adult students and, didn't even dance as kids and have picked it up in adulthood. And I think it's just, there's so many wonderful benefits for dance. And so I absolutely agree. That being said, I guess all of this advice would also apply to adult students too. And I think what you mentioned about how like having your own goals, even as an adult student. And yeah, if your whole class is going on Pointe and you don't want to, don't do it.
Yeah.
It's not for everyone. It's wonderful if you want to do it. But yeah, I think individual goals is such great advice for any dancer at any stage of their training or career. Perfect. Great. We've talked a little bit about some common misconceptions and, debunking this about hypermobility and hEDS that have come up with, clinicians, dance teachers, parents, dancers. Are there any other ones you wanted to maybe mention that you've come across in your work that might be helpful for anyone?
I think one that I want to mention is that it's not just when you're dancing that you should be thinking about your hypermobility. I notice a lot of dancers, when they're in the back of the room waiting to go across the floor or whatever, they're hanging on their joints. And they're more conscious and making more of an effort to control their hypermobility, especially in their standing leg. The gesture leg, you can kind of go a little bit more into that hypermobile range, but the standing leg, you should be more conscious of it. And then there's just, standing in the back of the room and they just sink into everything. So you want to make sure that you're thinking about what's best for your body all the time without going crazy, of course, but you want to just make sure that you're developing good habits. And we already talked about this a little bit, but hypermobility, it's not always an advantage. It can be a huge advantage, of course, but it has its pluses and minuses. For sure. I would also say another misconception is that strong and successful dancers are not struggling. They certainly can be. Probably the biggest misconception is that hypermobile EDS and HSD, that these are just joint conditions. And we've obviously already talked about that because they can affect multiple bodily systems. And also the last one I want to say is pain. There are people who they look like they're doing fine, but they're having a lot of pain. And so just because somebody looks okay doesn't mean that they're not in pain.
Yes, that's so true. And something you said made me think, even just again, maybe talking about Pointe, going on Pointe, and how, in ballet, we love those bendy, flexible feet and ankles, especially in a Pointe shoe. But, having taught ballet myself so much over the years, and I've put so many students on Pointe, and sometimes it's those students with those super flexible feet that actually struggle more than the ones who don't have the flexible feet, and how, core stability is so important.
Yes.
For, again, with Pointe, going on Pointe. I've talked about going on Pointe a lot here on this podcast.
That's
But,
good.
we get so focused on, well, okay, we just need to do like a bunch of releves. It's like there's a lot more to it than that. And I think sort of what you're saying here too is the same thing just for hypermobility in general. And again, if you can work with a physical therapist or a dance medicine specialist who can really assess you and find your weaknesses and help stabilize things, it can just make such a big difference. So just such
Yeah.
wonderful advice.
Yeah, and there's two other things that I want to quickly point out about going on Pointe or being on Pointe. So
Please
one
do.
is, so one is if you have a hyperextended knee, that's going to push your tibia more forward, and so you're going to need to be even more over your box. So if you have a hyperextended knee but not really hypermobile ankles, you're going to struggle more. But if you have hypermobile ankles, developing that ankle stability is harder. So, but if you think about it from a line standpoint, right? And I'm this way. I love the beautiful lines, the banana feet.
We all do.
Yeah, we all do. If we did ballet for long enough, we all do. But if you think about it, if you have that hyperextended knee, then you really need to have that ankle range of motion in order to be on point correctly. But I interviewed now Dr. Moira McCormick, who was a dancer with the Royal Ballet and lead physiotherapist for the Royal Ballet, both for the first episode of the podcast and episode 200, because I thought that would be fun to have her come back. And she said when I very first interviewed her that when she's working with a hypermobile dancer at the Royal Ballet or the Royal Ballet School, she actually has them go on Pointe later than other dancers. And I worry because I feel like there's a lot of people who are getting dancers up on Pointe earlier nowadays. So I love that you talk about that a lot on your show. I love your show, by the way. And I love what you're doing because it's so important for dancers to have this information.
Well, thank you. That means a lot coming from you. So thank you so much. Yes, I loved your full circle moment on your podcast with your first and your 200th episode having the same guest. And yeah, wonderful episode. Again, highly, highly recommend Bendy Body's podcast to everyone listening. So I guess just to kind of wrap up, you've given us so much wonderful advice today, but if you were speaking to a young dancer who might be listening to this episode and they suspect they might have, they might be hypermobile or have EDS, or they hear themselves a lot in the things you've been mentioning. Again, you've given so much wonderful advice, but just to kind of seal the deal here, what would you recommend as their next steps?
Mm-hmm. Well, number one, don't panic. A lot of people, I think, panic and like, oh my God, especially nowadays, you can look so much up online, right? And I get messages all the time from people, I looked this up, I did an AI search or whatever. And so it's really challenging now, right? Because there's so much information. So make sure you're getting reliable sources, start paying attention to the patterns, what's going on in your body, like I said earlier, get with a physical therapist or a Pilates instructor who is specifically dance medicine trained, because otherwise I feel like so many physical therapists, they don't understand dance. If you possibly can. Of course, there's great physical therapists out there that are not part of IADAMS, they're not dance medicine trained, but that's just a really good place to start. And I do want people to really understand that early recognition can really help support your long-term health and your performance.
Wonderful. So we've mentioned your podcast many times. And again, it's wonderful. If listeners want to learn more about you or your podcast or anything, where can they find you online?
So they could go to bendybodyspodcast.com or hypermobilitymd.com. So I basically have kind of two arms. I have Hypermobility MD, which is my medical practice, but it's very, very small. And my Bendy Bodies, I do coaching through Bendy Bodies. So I work with people one-on-one anywhere in the world. And I also have a physician assistant, a certified physician assistant that works for me for Bendy Bodies. And her name is Rebecca Gluck. And so people can work with her also. She's really outstanding. She has a lot of many, many years of experience working with people who have EDS and HSD. So those are kind of the main things. I know I've talked about my podcast, I've talked about the newsletter, but the coaching and the medical practice are the two like one-on-one options. And I also offer professional mentorship. So I work with a lot of, like I said, dance medicine, physical therapists, Pilates instructors, physicians will contact me from all over the world. I've worked with physicians from all over the world who are like, I want to start working with patients with EDS. What do I need to know? So
Awesome. That's such you are such a wonderful resource for all of those things. So, it has truly been a pleasure talking to you today, and thank you so much for all of your knowledge, for sharing all of that with everyone. I've done some more generic things about hypermobility here, but there's always so many questions that are so
Mhm.
specific, and I hope that this episode will kind of answer a lot of those and give some people some more resources they can turn to. So, Dr. Linda Bluestein, thank you again so much. This has truly been a pleasure, and I can't wait for the next episode of Bendy Bodies.
Well, thank you so much for having me. Keep up the great work. I think it's fabulous what you're doing, and you're getting critical information into the hands of dancers who, other athletes, they have sports medicine physicians, and they have so many more resources. So dancers really need this information. So please keep up the great work.
Oh, thank you. And that concludes my conversation with Dr. Linda Bluestein. Thank you for joining me today for the Ballet Science Podcast. Whether you are a dancer, teacher, student, or simply curious about the mechanics behind movement, I appreciate you being here today. Each week, we will explore the intersection of science and ballet, from injury prevention and biomechanics to nutrition, mindset, and everything in between. If you enjoyed this episode, please follow this podcast, leave a review, and share it with your friends and dance community. If there are specific topics you'd like to hear about in future episodes, feel free to share them in the comments below. You can also follow Ballet Science on social media and visit our website at ballet.science for additional information. Thank you again for tuning in, and I look forward to seeing you next time on the Ballet Science Podcast.